Morning, everyone. I am Dr. Laura Lacher, and welcome to Medical Grand Rounds. Particularly excited about our talk today. We will start with some reminders, logistics, and then introductions. Please be sure to join us next week as well. We will be hearing a talk, Screening and Management of Sexually Transmitted Infections in High-Risk Groups, given by our own infectious disease specialist, Dr. Imran Mohammadi. And just a few logistics. Grand Rounds is now a joint effort between Providence Portland Medical Center and Providence St. Vincent Medical Center. We're very excited for that collaboration and also to bring Grand Rounds always available on the Teams Live virtual format. We often meet here Tuesday mornings at 8 a.m. at Providence St. Vincent, and sometimes Grand Rounds is also available at noon on Tuesday at Providence Portland. There will always be a weekly invite to indicate where you are able to view Grand Rounds. You can always earn CME credit for being live with us in person, for watching virtually, or by watching a recording of the event. And that video is always available as the same link as the Grand Rounds invite. Today, I'll be monitoring the Q&A throughout today's session, so please go ahead and post any comments or questions for those of you joining us online, and I will mostly save those to the end of the presentation as time permits. And now I am particularly delighted to introduce today's 2024 Kammer Memorial Lectureship. Dr. Kammer, as many of you may know, was the first board-certified endocrinologist in Oregon and an icon at Providence Portland Medical Center for over 45 years. In addition to managing a busy clinical practice, he also conducted high-quality clinical research and served as Associate Director of the Internal Medicine Residency for 30 years. His tireless dedication to clinical excellence and scholarship was an inspiration to medical students, residents, and faculty alike. It is in his honor that I am very excited to introduce this year's Huldrych Kammer Endocrinology Lecturer. We are joined today by Dr. Michael McClung, the founding and Emeritus Director of the Oregon Osteoporosis Center, where he has cared for patients with metabolic bone disease and was principal investigator for many of the large osteoporosis clinical trials. For more than 20 years, he was an assistant director of the Providence Portland Department of Medical Education, where he worked closely with Dr. Kammer. And like Dr. Kammer, Dr. McClung has been actively involved in education, has developed clinical guidelines for national and international societies, and has received multiple teaching awards. Among them, the Leon Spiroff Teaching Award from the Menopause Society and the Olaf Jonel Science Award from the International Osteoporosis Foundation, where he currently serves on the board. We are delighted to learn today from Dr. McClung, and what an appropriate tribute to Dr. Kammer. Thank you so much.
Laura, thank you, and good morning to all of you. It's a great pleasure to be back at St. Vincent for Medical Grand Rounds, and particularly in the role of the Kammer Lecturer. As Laura said, I had the marvelous experience and opportunity to work with Dr. Kammer from the time I arrived in Portland in 1976 until he passed away in 2003. So to get to be here and remember him is a special treat. As mentioned, Cam was the first board-certified endocrinologist who in Oregon, arriving here after endocrine training at the Cleveland Clinic and time in the military service, arriving in Portland in 1949. He pioneered the use of radioactive iodine, using radioactive iodine from the Reed College reactor, which was a unique thing back in those years. He would actually go to Reed, retrieve the radioactive iodine, and treat his patients, and wrote a pioneering article about the use of radioactive iodine in 1954. He also pioneered the use of single daily dosing of antithyroid drugs. Before that, it was given 3 times a day, and compliance was poor, and this approach made things much easier for many patients with hyperthyroidism. He wrote many papers about other aspects, the full gamut of endocrinology, from hypervitaminosis D to hypoglycemia to pituitary issues to sexual differentiation issues and parathyroid disease. So he was truly gifted in the entire breadth of endocrinology. He's one of the few people who is from Oregon with a publication in the New England Journal of Medicine, being a co-author on the study that looked at short-term antithyroid drug use for the treatment of Graves' disease. In 1972, he was promoted to professor at OSSU, and then, as mentioned, when Dr. Gilbert came back to Portland from his training in Dallas, the first thing he did when he became the chief of medicine at Portland Providence Medical Center was to recruit Cam, who had been his neighbor in earlier years, to join the faculty. And that helped set the stage for the quality of the educational experience that residents at Providence had during those years. Cam was devoted both to his patients and to his students, and the respect was reciprocated by both patients and his students. And Cam was amazingly supportive of young colleagues, including me, when I first came to town in 1976. He would come to the weekly endocrine conference at the medical school and was wonderfully supportive of me in my early career, and then especially when I was recruited to join the group at Providence in 1987. So he was received a number of awards, including the prestigious Laureate Award given by the Oregon chapter of the ACP in acknowledgement of Cam's lifelong contribution to medicine and his example of professional excellence. So this lectureship was set up by Cam prior to his death with the intent of having a nationally recognized endocrinologist come to Portland and be available to teach not only the primary care physicians in the city, but to be a resource for endocrinologists in town as well. This, we think, is the 20th annual Kammer lecture, and it's our intent at Providence to have this our lectureship continue for a long time. And to do that, our goal over the next year or so is to raise support for that. There has been a very generous offer to match the first $50,000 in contributions to the Kammer Lecture Fund. I'll give you the information about how one can contact the Providence Medical Foundation at the end of the presentation. So let me address some issues about managing osteoporosis. In the 40 years that I've been involved in caring for patients with osteoporosis, we have learned a lot. In the early days, when I and Eric Orwald set up the Bone and Mineral Clinic at the medical school in the late 70s, there wasn't a definition of osteoporosis. Bone density testing was not available for another 10 years. Treatments for osteoporosis were not available until the mid-1990s, and guidelines for how we approach the management of patients were not available until even later than that. So to have watched the evolution of the management of osteoporosis has been one of the very fun parts of my career. But there's still some unanswered questions about the practical management of osteoporosis, and I would like to address some of those. Disclosures are that I've had relationships with companies that made all of the drugs for osteoporosis, and including Amgen, which is the company that makes both Prolia and Avenidine now for osteoporosis. And as mentioned, I'm on the board of the International Osteoporosis Foundation. So we know that osteoporosis is defined as low bone density, but it's much more than that. It's a disorder characterized by low bone density with a deterioration of the architecture that impairs bone strength and increases the risk of fracture. And we have a number of drugs that effectively and quickly reduce the risk of osteoporosis. So it's important to appreciate that osteoporosis is more than just low bone density. There is a deterioration in the architecture of the skeleton that happens as bone loss happens after menopause in women and with aging in men. And it's that architectural deterioration which is the major contribution to the skeletal fragility and the increased risk of fracture. In women at menopause, there's a relatively rapid phase of bone loss. About half of the bone loss that women experience between menopause and age 80 happens within a few years in the perimenopausal years. And there is a marked impairment of the skeletal microarchitecture during that phase of rapid bone loss. Then after that rapid phase is over, there's a more gradual loss of bone density for the remainder of a woman's life. And the average age at which a woman reaches the threshold of bone density that we define as osteoporosis is about age 80. But for women who come to menopause with lower bone density, for example, a T-score of -1, they have the same dynamic in terms of their bone loss, but reach a level of osteoporosis and in their mid-60s. So this will come back as we talk about indications for screening for osteoporosis. We shouldn't wait until age 65 before we begin looking for this. The changes in bone density, of course, in men is different. They don't have the rapid loss of bone density associated with menopause, but they do experience the age-related bone loss over their life beginning in middle age. We define osteoporosis on the basis of a bone density test based on epidemiologic criteria that were looked at and defined in the early 1990s. Osteoporosis is defined as a T-score of bone density of -2.5 or lower. That is 2.5 standard deviations below the average value in young, healthy adults. Normal bone density is described as a T-score of -1 or greater. And then there's an awkward intermediate zone called low bone mass, or often called osteopenia, with T-scores between -1 and -2.5. We know that measurement of bone density is a very important and powerful predictor of fracture risk. So shown here is the 10-year probability of a hip fracture on the y-axis as a function of the hip T-score on the x-axis. And then that relationship is stratified by different decades of age. There's a powerful interaction between age and bone density in terms of their relationship to fracture risk. But at every age, the lower the T-score, the higher the risk of fracture. But for any given T-score, the older the person is, the higher the risk of fracture. Osteopenia, the interval between -1 and -2.5, is not a useful clinical diagnosis. As you can see between the vertical lines, there are individuals within the category of osteopenia who are at very low risk and others who are at very high risks. So asking the question, should we treat osteopenia, is not a very good question. We need to know much more about the patient and other risk factors to identify the individuals who are in the osteopenia category, but who are at high risk and deserve attention. So the prevalence of osteoporosis is age-related for postmenopausal women. Before age 65, in the range of 50 to 64, 13% of women have bone density criteria that are consistent with osteoporosis. And of course, the ratio is higher in older women. The incidence and prevalence of osteoporosis, of course, is much lower in men at both age groups than in women. About 50% of women will experience a fracture related to osteoporosis in their lifetime. The fracture risk is somewhat lower in Black and Asian women compared to white or Hispanic women, but for all of us, there is an age-related decline in bone density, bone strength, and an increasing risk of fracture. So all of us, regardless of whether we are specialists involved in endocrinology, rheumatology, or geriatrics, or primary care physicians, all of us who see older individuals will have a number of patients with or at risk for osteoporosis in our practice, and all of us then should at least be comfortable and confident in approaching the evaluation and the initial management of patients with osteoporosis. Bone density testing is the way we identify patients with osteoporosis. Everyone knows that women over the age of 65 are candidates for osteoporosis testing by DEXA because it's reimbursed by Medicare. But what's not appreciated is that for women who are younger than age 65, but who are postmenopausal, bone density testing is also indicated if they are at risk for developing osteoporosis or fracture. And that would include individuals with a previous fracture, women who are thin. There's a strong correlation between body weight and bone density, and those with a family history of osteoporosis. If those criteria are undertaken, we can then identify women earlier in the game and not wait until they have severe osteoporosis at age 65 before we identify them to intervene. So we shouldn't wait until age 65 to consider osteoporosis screening. The diagnosis of osteoporosis is based on things other than simply bone density. If a patient has a T-score of -2.5 or lower in the lumbar spine or proximal femur, then we make the diagnosis. But the clinical diagnosis of osteoporosis can be made in individuals, in postmenopausal women and in older men who have a history of hip or spine fracture, irrespective of bone density, because we know that those fractures, as we'll talk about in a moment, are very strong predictors of subsequent fractures. Also, postmenopausal women who have low bone density and who have had other fractures, other important fractures, those are the proximal humerus, pelvis or distal forearm, patients with multiple fractures, patients with fractures while on therapy, or patients who have a combination of other risk factors that put them at high fracture risk using a fracture risk algorithm called FRAX that I'll mention on the next slide. So FRAX is a tool that was put together by a group in Sheffield under the auspices of the World Health Organization back in 2008. And it's a very scientifically based algorithm that incorporates bone density and a variety of other relatively independent risk factors for fracture. And by going through the computer-based algorithm or the algorithm on the software of the DEXA machine, one can then express the probability of the 10-year probability of experiencing a major osteoporotic fracture or hip fracture. And this can be helpful when there is uncertainty about whether a patient is a candidate for therapy, and being able to assess their fracture risk with this algorithm is a very useful tool. Since 2008, there's been one addition to the FRAX algorithm. There is a technology called trabecular bone score, a technique that uses the lumbar spine DEXA scan and subjects it to another algorithm that looks at the heterogeneity of the distribution of density on that scan, and that has been shown to be an indirect reflection of the microarchitecture of the trabecular component of the spine. And one can then adjust the fracture probability by adding the trabecular bone score to the FRAX tool if and when a TBS is available in the DEXA laboratory. We've known from the very early years that the major risk factors for fracture are being old, having low bone density, having had a previous fracture, and falling. as the proximate cause of fracture. In the last several years, we've come to appreciate that a recent fracture is by far the most powerful predictor of another fracture. Shown in the graph is the relative risk of having a second fracture on the y-axis as a function of time on the x-axis since the first fracture. And at the end of the first year, the relative risk is increased more than fivefold. And then with time, the relative risk comes back to an average of about a twofold increase in risk. That relative risk numbers aren't very helpful in understanding how important this is. In absolute terms, for postmenopausal women who experience a fracture, 10% will experience another fracture within the next year. And if that fracture, the first fracture, is a spine fracture, then 19 to 20% of women will experience a fracture within the next year. The appreciating this, a number of the recently updated guidelines from societies have recognized and defined a new category of patients at very high fracture risk. That includes patients with a recent fracture, that is within the preceding year, or patients with multiple fractures, fractures on therapy, very high fracture probability by the FRAX tool, a history of frequent falls, or very low bone density. All of those criteria would put a patient into the category of very high fracture risk. So at Providence, when the residents were with me in the clinic and we saw patients with fractures, I would attempt to have them consider a fracture as the patient having had a bone attack. When a patient presents with a heart attack, the residents instantly, of course, are all over a risk assessment algorithm, and the patient rarely leaves the hospital without management plans to reduce the risk of a second heart attack. Patients with fractures all deserve risk assessment. They might not all need therapy, but certainly when a patient has a fracture, they need to be thinking, or we need to be thinking with them about their risk of fracture to then intervene when appropriate to reduce the risk of the second fracture. So appreciating that having a fracture is a very powerful risk factor for another fracture, which we have known now for a number of years. Despite that, the proportion of patients who are treated after a fracture is woefully inadequate and low. So in a real-world study that we recently published, we looked at more than 100,000 women over the age of 50 in a commercial and Medicare health plan databases who had a fracture and then who were followed for an additional 12 months after the fracture. The average age of this cohort was only 60.8 years, so not an extremely older cohort. And almost half of the women in the cohort were between ages 50 and 64. In the 12 months after the fracture, only 13.8% of the patients had a bone density test to assess their risk of subsequent fracture, and only 14% received osteoporosis therapy. If I told you that the cardiology service only treated 15% of patients who had a heart attack before they went home from the hospital, you would say that they're way behind the times. We ought to be doing in osteoporosis at the same level that we talk about in cardiology. During that 12-month follow-up, 26% of patients had another fracture, that the risk of which could have been substantially reduced if therapy had been introduced. So how do we go about management? General measures of good nutrition, especially adequate intakes of calcium and vitamin D, regular physical activity, being nice to your kids are recommendations that we can make to every adult, irrespective of whether they have osteoporosis. That's just good health measures that's appropriate for everybody. The recommended intake of calcium is between 1,000 and 1,200 milligrams daily total intake. That includes being given credit for 300 milligrams of calcium in a dairy-free diet, plus whatever additional calcium comes from dairy foods and other calcium-rich nutritional sources, and which means that no one needs to take 1,000 milligrams of calcium as a daily supplement each day. There is some concern about the relationship between very high intakes of calcium and vascular calcification and myocardial infarction risk. That risk is not an issue if the intake of calcium is appropriate within the limits we described. Vitamin D deficiency occurs quite commonly. Many large prospective trials have demonstrated that for healthy community-dwelling adults, giving vitamin D is not associated with improved clinical outcomes. But in those studies, the average level of vitamin D was in the low normal range. Like other nutrients, once a nutrient is adequate, giving more is not helpful. Studies looking at replacing or correcting vitamin D deficiency in terms of what it does to improved outcomes are much fewer in number, but it is suggested that for patients who clearly have vitamin D deficiency, correcting vitamin D deficiency can reduce the risk of falls and perhaps reduce the risk of fracture. Because hypocalcemia is a potential side effect or adverse event of many of our osteoporosis drugs, it's recommended that for all adults who are being treated with an osteoporosis drug, that vitamin D supplements in the dose of 1,000 to 2,000 units a day would be appropriate. Regular physical activity is important, but it will not, cannot, and does not either prevent or restore the bone loss that happens across the menopausal transition or age-related bone loss. It would be ideal if we could rebuild the skeleton with weight-bearing exercise, but it's a myth that that happens in those of us who have completed our skeletal maturation and growth. And of course, avoiding habits that are harmful to the skeleton is appropriate advice. So these general measures are important, but are not sufficient either to prevent osteoporosis and certainly not sufficient as treatments for patients that we have recognized as having osteoporosis and at high fracture risk. The drugs we have fall into two broad categories. Anti-remodeling drugs, they're often called anti-resorptive drugs, but they inhibit bone resorption, but they also inhibit bone formation. And because of that, these drugs, while improving bone density and bone strength modestly, do not correct the architectural deficit that characterizes osteoporosis. On the other hand, osteoanabolic or bone-forming agents activate new bone formation, restore architectural integrity, and have been shown to be superior to anti-remodeling drugs in terms of their effects on bone density and fracture risk reduction. The osteoporosis is a chronic disorder for which there is no short-term fix. And management of patients with osteoporosis is a lifelong, certainly a long-term proposition. Recently, we've been made aware that measurement of bone density while the patient is on therapy is effective in reflecting the patient's current risk of fracture. Shown here in the graph, on the x-axis is the on-treatment hip T-score achieved, and on the y-axis, the risk of having a non-vertebral fracture in the year after that test was measured. And this relationship, low bone density being associated with an increased risk of fracture, looks just like the relationship in untreated patients. But these are the first data showing that on treatment, in this case, with denosumab is related, that the T-score achieved on treatment with denosumab is associated with the patient's current risk of fracture, and allows us to actually imagine that perhaps an appropriate target of hip bone density might be a T-score of -2 or maybe slightly higher as a target to try to get to optimize the patient's risk reduction. We also know that no one drug is right for the patient for his or her lifetime. And we are learning about how to use drugs in optimal sequences over time. And we'll talk about some of those sequences in the next slides. The society guidelines that have been updated in the last 3 or 4 years all recommend that we make initial treatment decisions based upon the patient's fracture risk at the time they're seen. For patients who are at very high risk of fracture is where the anabolic or bone forming drugs are recommended. These are patients who are at very high or imminent risk. We want a drug that very rapidly improves their bone density, rapidly improves their bone strength, and rapidly reduces their fracture risk. The justification for that recommendation comes from several sources. You know, as I've mentioned, only these osteoanabolic drugs that include parathyroid hormone receptor agonists, both teriparatide and abaloparatide, or an anti-sclerostin monoclonal antibody called romosozumab. These drugs markedly improve and increase bone formation and are capable of restoring the trabecular microarchitecture back toward normal. So that's one of the justifications for considering a bone-forming drug as initial therapy. The bone density responses to the anabolic therapies are greater and faster than we see with the usual anti-remodeling drugs, either denosumab or alendronate. And then there are data from 2 studies that prospectively showed that teriparatide and romosozumab were superior to oral bisphosphonates in terms of fracture risk reduction, and that fracture risk reduction that's seen with 1 to 2 years of osteoanabolic therapy persists for at least 2 or 3 years after patients are then transitioned to maintenance therapy with a bisphosphonate or denosumab. Another reason to consider the use of a bone-forming drug first is that if we start with a drug like a bisphosphonate, the standard treatment for osteoporosis, and then decide that the patient's response was not adequate and then choose to begin an anabolic drug, the bone density response is much smaller than it would have been had the patient received the bone-forming drug first. So shown here are the bone density responses to teriparatide and romosozumab in the lumbar spine and in the total hip, in patients who were treatment naive, shown in the white bars, patients who previously received bisphosphonates, shown in the orange bars, or patients who had previously been treated with denosumab. And in both the spine and especially in the hip, the patients who had received previous anti-resorptive therapy had much smaller responses than did the patients who were treatment naive. So if we want to take optimal advantage of the bone-forming effects of the bone-forming agents, they need to be used before the anti-remodeling drug is used. So the sequence of a bone-forming agent followed by an anti-remodeling drug is the most effective therapy we have for treating patients with osteoporosis, and certainly is recommended for patients who are at very high risk of fracture. And if cost were not an issue, and as we gain more experience with the newest of those agents, romosozumab, which has only been available for the last 5 years, it may be that we'll come to the point that all patients with osteoporosis would be candidates for a bone building drug as the initial treatment. And then once that improved bone structure, bone strength is achieved, we can keep that new better bone in place for a long time with the intermittent use of anti-remodeling drugs that we'll come to. For patients that are the usual kind of patients, it's now currently recommended that we choose between a bisphosphonate and denosumab. These are the only two drugs that we consider for long-term osteoporosis therapy. So I think it's useful to look at what happens to long-term therapy with each of the two drugs to both compare and contrast those effects. A number of studies with bisphosphonates have been shown, have been extended out to 9 or 10 years, and each of them shows these points. There is a plateau in the increase in hip bone density after 3 or 4 years. So shown in the top graph is the hip bone density over 9 years of therapy with intravenous zoledronate therapy, probably the most potent of all of the bisphosphonates we have. And again, after the 4th year, there's no additional increase in bone density despite ongoing therapy. Shown in the lower graph is the incidence of non-vertebral fracture in the first 3 years in the placebo group and the treated group, showing the 25% reduction during the first 3 years of therapy. Then in the right-hand bar is the incidence of non-vertebral fracture during the second 3 years of therapy with no incremental benefit. So that reduction in fracture risk is maintained, but is not improved with long-term therapy. So there is no incremental benefit of continuing bisphosphonate therapy for more than 5 years at a time. Because of the relatively slow offset of bisphosphonates, because of their unique pharmacology of binding tightly to the bone matrix, and then when treatment is stopped, the effect of inhibiting bone remodeling continues for some time, gives us the opportunity to consider what's called a bisphosphonate holiday, a temporary interruption of therapy in some patients. That concept was introduced more than 10 years ago, but has still resulted in confusion about how to operationalize a drug holiday. So let me try to explain my approach to that. It's recommended that after 3 to 5 years of bisphosphonate therapy, we reevaluate the patient and divide them into those at low or not low risk of fracture. That was not very helpful terminology. So in our clinic, we actually do it this way. If after 3 to 5 years of therapy, the patient no longer meets the criteria for being treated, then we can consider discontinuing therapy at least for an interval of time and consider a drug holiday. Whereas for patients who continue to meet the criteria for therapy, then continuing treatment would be appropriate. For patients who undergo a drug holiday, they should be monitored at intervals of every 2 to 3 years, and when the patient again meets the criteria for treatment, either because of a decline in bone density, the acquisition of other risk factors, or having a fracture in the interim, then one would look at the menu of treatment options and begin treatment again. But for patients who continue to meet the criteria for treatment after an interval of bisphosphonate therapy, continuing treatment is recommended. But the question is, do we continue a bisphosphonate, or should we consider switching to another drug? I've already shown you that there is no additional benefit for continuing a bisphosphonate for beyond 5 years. If a patient remains at high risk of fracture after 5 years of bisphosphonate and continues for another 5 years, they will still be at high risk of fracture. So it's, but in addition to that, we know that there is a duration-related increase in the risk of a rare but important adverse event, an atypical femoral fracture. And that risk is particularly high beyond 5 years of therapy. So if we have a patient who remains at high risk of fracture after 5 years of therapy, continuing a bisphosphonate will not improve their fracture risk, but will expose them to the risk of atypical femoral fracture. Just my personal view that there is no justification for continuing a bisphosphonate for more than 5 years at a time in an individual patient. It doesn't mean that we can't come back to use bisphosphonate later in the course of a sequence of therapy, and I'll explain how we do that later on. In contrast to continuing therapy, there are data showing that if we switch from a bisphosphonate to denosumab, there is an added increment of bone density in the graph on the left. Shown on the right are studies where patients had been on bisphosphonates for an average of 6 years, and then were randomly assigned to receive either romosozumab, shown in blue, or teriparatide, shown in gold, bone building drugs, and particularly with romosozumab, a substantial additional increase in bone density is noted. So it's my personal view that for patients who remain at high risk of fracture after 3 to 5 years of bisphosphonate therapy, that switching to a different osteoporosis drug, either denosumab or an osteoanabolic agent, would be appropriate rather than continuing the bisphosphonate. Denosumab is a different story. Denosumab is a monoclonal antibody that was designed to block and interfere with the activity of rank ligand, an osteoblast osteocyte-derived a molecule that is required for the activation of osteoclasts before they can become mature bone-dissolving cells. And by inhibiting rank ligand, then the osteoclastic bone resorption is markedly inhibited, and as that resorption is inhibited, so is bone formation. It's administered as a subcutaneous injection every 6 months, so compliance with denosumab is improved in part because we, as the clinicians, assume some responsibility for ensuring that patients come back at the right time to receive their dose. In the very large phase 3 pivotal trial, over 3 years of therapy, there was a 68% reduction in vertebral fracture risk, a 40% reduction in hip fracture risk, and that risk reduction was seen within the first 6 to 12 months of therapy. In the 10-year follow-up, we've observed that there is a progressive and continuous increase in hip bone density over the full 10 years of therapy, unlike the plateau that we see with bisphosphonates. And shown in the right bar graph, the longer the patient is on therapy, the lower is the risk of non-vertebral fracture, despite the fact that patients are growing older, which, as we've said, is a risk factor for fracture. So there is no evidence of loss of efficacy, at least over 10 years of bisphosphonate therapy. And consistent with the differences that I've just described, a very recent large observational study in which more than 90,000 women in the United States who were given denosumab were matched from among almost 400,000 women who were treated with alendronate. And then the women, after a sophisticated matching process, were followed for up to 8 years. At the end of the first year, there was a 9% lower frequency of major osteoporotic fracture with denosumab compared to alendronate. That's hard to see on the graph, but because of the very large numbers, even that small difference was statistically significant. But more importantly, the longer the patients were on therapy, the greater the difference was in the fracture rate between the two treatment groups, so that at the end of 5 years, the relative risk reduction was 31% with denosumab compared to alendronate. Again, these data are very consistent with the longitudinal changes in bone density and fracture risk reduction that I've shown you previously. Over the 10 years of follow-up in the very large denosumab extension trial, there were no side effects that were related to the duration of therapy. So shown here are the rates of a variety of adverse events during the 3 years patients were in the placebo group, and then that group was received open-label denosumab for an additional 7 years, and there was no increase in the rate of adverse events when patients switched from placebo to long-term denosumab therapy. Very small numbers of cases of osteonecrosis of the jaw and 2 cases of atypical femoral fracture were observed in the almost 80,000 patient years of follow-up in this study. Of the 13 cases with osteonecrosis of the jaw, 6 of those had ill-fitting dentures that resulted in erosion of their hard palate, and just by correcting their dentures while the patients continued on therapy, the lesions healed. Of the other 7, all but 1 had resolution of their osteonecrosis with conservative therapy while the patients continued on treatment. With only 2 atypical fractures, one cannot, of course, make a statement about the relationship between the duration of denosumab therapy and the risk of atypical femoral fracture. So to summarize about denosumab long-term therapy, there's no limit to the duration of treatment. The study lasted for 10 years, but for disorders like diabetes, where the studies may last for 3 to 5 years demonstrating positive outcomes, we don't say, well, the study only lasted for 5 years, so now we have to stop therapy. I've heard that said about denosumab, that because the study only lasted for 10 years, that after 10 years we need to consider stopping therapy. That's not the way those studies should be interpreted. Osteoporosis, like managing diabetes and like managing hypertension, requires long-term management, because if and when we discontinue therapy, the benefits go away very quickly. So there is also no justification for a holiday with denosumab. Beginning in the early 20-teens, patients who discontinued denosumab reported an increased risk of multiple vertebral fractures within months of discontinuing therapy. And there was confusion, particularly from the ACP guidelines that recommended, when they were published in 2017, that postmenopausal women with osteoporosis should be treated for 5 years without monitoring, period, without a differentiation between bisphosphonates, which that might have been an appropriate set of advice, and denosumab, where that is clearly the wrong advice. So if therapy is stopped because of the rapid off effect when denosumab is discontinued, that's not unusual. That's the way drugs work. When you stop therapy, the effect goes away quickly. But with denosumab, there is a rebound in bone remodeling, very rapid decrease in bone density, and very rapid loss of protection from vertebral fracture. So patients need to appreciate and understand this as treatment is started. We need to encourage and help them be back every 6 months for an on-time next dose. And then if treatment is discontinued, simple steps need to be taken to switch to a bisphosphonate at least for a year or 2 to mitigate the rebound in remodeling and protection from fracture. Concern about discontinuing denosumab and the risk of vertebral fracture if therapy is discontinued shouldn't dissuade us from considering denosumab when we think that it's an appropriate therapy for patients. Lastly, let me talk about an idea of maintenance therapy after the initial treatment phase of osteoporosis is over. When we begin therapy, again, we attempt to improve bone mass, improve bone strength, and reduce fracture risk as much as we can. But ultimately, a steady state is reached, and I suggest that then we often don't know what to do. But I'm going to propose that we consider a strategy of maintenance therapy where we take advantage of the slow off effect of bisphosphonates by administering bisphosphonates intermittently at relatively long intervals to maintain the benefit that happened. We've got good evidence to support this. Shown on the left is our data in younger postmenopausal women who were given alendronate for 2 years, and then therapy was stopped, and their hip bone density was in the placebo group. Bone density was lost. Alendronate prevented that from happening, and then in the 3 years off therapy, that benefit was maintained. In the right-hand graph is the change in total hip bone density in a group that received placebo, shown in the lower line, or a group that received 1 dose of intravenous alendronate, and then the patients were followed for 10 years. And the group that got 1 dose of zoledronate had bone density maintained at the hip region for more than 5 years. This suggests that we could then consider, after the initial treatment phase, and we get the patient to a new steady state, hopefully at a relatively low fracture rate, that then intermittent therapy with alendronate 2 years on, 3 or 5 years off, or 1 dose of zoledronate every 5 years could be used to maintain the benefit derived from the initial therapy. If the treatment could be restarted, of course, if a fracture occurred or if other changes in the patient's medical situation resulted in their meeting criteria for therapy again. And in theory, this could be a way to maintain bone density over the long run. So let me have you consider 3 patients with me briefly. One patient who is at moderate risk of fracture, where perhaps treatment with alendronate for 3 or 4 years puts the patient now at modest risk. They're a candidate for a drug holiday, after which intermittent bisphosphonate maintenance therapy would be appropriate. A patient at higher risk that we need to do more with could consider denosumab therapy for a number of years, then switch to a bisphosphonate to prevent the rebound in remodeling and the loss of effect, after which intermittent bisphosphonate maintenance therapy would be appropriate. And for patients at very high risk, we could consider a course of anabolic therapy, followed then by denosumab for a number of years. And if the patient transitions to a level of modest risk, then transitioning to intermittent bisphosphonate maintenance therapy for the remainder of their experience would be appropriate. So patients with osteoporosis and a high risk of fracture can be readily identified and are commonly encountered in our general medicine practices. Primary care physicians, I think, should be confident about how to identify patients at high risk of fracture and confident about initiating therapy based upon the assessment of that patient's risk. Every postmenopausal woman and older man who experiences a fracture should undergo fracture risk assessment, not necessarily treatment, but at least they should be assessed. The initial treatment decision should be based upon the patient's risk of fracture at the time, and then we know that the sequence of an anabolic drug followed by an anti-remodeling agent is the most effective treatment strategy that we have. And then we have a strategy to consider for long-term maintenance after the initial treatment option has been undertaken. In most patients, osteoporosis can be managed both effectively, quite simply, and is, I believe, a strategy that all of us as primary care physicians can undertake. Like other chronic disorders, treatment of patients with osteoporosis requires long-term, if not lifelong, management. There's no single treatment strategy. Like other diseases, we need to individualize our approach, including the patient's perspective and objectives in those decision-making. This is a picture of my late wife, Betsy, who worked with me for many years in our osteoporosis clinic, and she would remind me as we went to clinic that we weren't there to treat osteoporosis, we were there to treat patients who had osteoporosis, and individualizing therapy was a big part of that. So it's been a great honor to present the 2024 CAMR lecture. As I mentioned earlier, we want to continue the idea of the CAMR lectureship into the future. Here are ways to communicate with the Providence Medical Foundation if you want to help us in that effort. I'll leave this up while we encounter questions and discussion. Thank you very much for your attention.
Many thanks, Dr. McClung. I will open it up to questions here in the room first.
Nice talk, Mike. I wonder if we're missing something in terms of with the anti-reabsorptive agents, in terms of if you look at patients who have breast cancer, either stage 2, 3, or 4, given an anti-reabsorption agent actually leads to a decrease in mortality or in terms of overall survival. You also see the same effect in terms of prostate cancer or multiple myeloma. I wonder if these effects are other than just in terms of bone, and can we leverage that in terms of people who have rheumatological diseases or inflammatory bowel disease?
Good point. That there are observational studies, again, suggesting bisphosphonates are associated with decreased mortality in patients with osteoporosis, in patients after hip fracture, and as you mentioned, in patients with breast cancer. So the mechanism underlying that is not quite clear, but I believe that if we consider therapy early to prevent osteoporosis, where bisphosphonates are a major part of our approach to that, that we could take advantage of that potential side benefit of bisphosphonate therapy as well. David.
You. I'm going to step in with a question here online for just a moment, noting great talk with new data. And I will acknowledge this may be partially addressed in Dr. McClung's approach to the 3 patients longitudinally. However, this question is regarding the bisphosphonate holiday. It seems that many older women would still, quote unquote, qualify for treatment, even if they saw a significant improvement in bone mineral density on treatment. For example, a 75-year-old woman with no risk factors who sees improvement to a T-score of -2 would still have a hip fracture risk of 3.5%, crossing over a treatment threshold. With your recommendation, it seems there would be many older women who we truly couldn't give a drug holiday to. Any comments on sort of operationalizing when nearly every woman we see still meets treatment threshold?
Sure. No, I think that's a good insight and a very good question, but that's where I think that my definition of who should be a candidate for a drug holiday helps. If the patient still meets the criteria for treatment, then I would not consider a drug holiday, or be less likely to consider a drug holiday. And if one of the criteria for therapy is a 10-year hip fracture probability of more than 3%, and if the patient still has that, meets that standard, then I would consider not recommending a drug holiday in such a patient. Dr. Gilbert? Sure. Well, this is a uniquely American problem. I get to travel all over the world to interact with osteoporosis people and strategies, and depending upon the health system that a patient is a part of, the barriers are more or less. So even between the contrast between the Providence system and Kaiser here in Portland is quite dramatic in terms of accessibility to therapy. And it depends entirely on the health system's guidelines and reimbursement policies for that. So in many cases, that's a big problem because those drugs are more expensive at the moment. Biosimilars for denosumab are about to appear on the market, and hopefully that will provide some relief. And so that the cost is always an issue with new, more effective therapies, of course.
Yes.
Should we be kind of, I guess in the ideal world, using bone turnover markers to kind of determine when patients are on anabolics, the kind of that maximize their anabolic window, or is it just not practically feasible and just kind of follow the 2 years?
Good thought. So there are tests that reflect either bone resorption or bone formation. I've not found them particularly helpful. They're great for research studies to show what the mechanisms of action are, but I've not found them particularly helpful in making decisions about which drug to use or when to make a switch in therapy. So for individual patients, the answers aren't nearly as clear as they are in groups of patients where we can make beautiful graphs to show what happens.
Well, I'd like to acknowledge that we are at 9 o'clock. So Dr. McClung, thank you so much for your talk today.